how I got to this point. Can you hear me in the back? I'm pretty vocal, so I don't usually have trouble being heard. Let me know if you do. I thought I'd introduce myself and kind of my path to my career now. I like to say I'm a 50%. I'm a clinician. I take care of people with kidney disease and high blood pressure. I'm 50% a researcher. I do epidemiology, population science, population data on the course of kidney disease and high blood pressure in the United States. I'm 50% a teacher because I go to medical school and I do a lot of teaching with medical students and residents. I'm 50% a mom because I have 3 kids. So I'm sure that adds up to 100% later. So this is kind of how I got into what I do, and I need my family to help with this. So this is my dad. My dad was his first in the family to go to college. He went to MIT because they'd heard that MIT was a good place for people who were good at math. And he then went on to a PhD. His parents didn't really understand what had gone wrong in college. He was going to have to keep going to school further. He got his PhD with a man by the name of Irwin Jacobs at MIT before Dr. Jacobs left for Qualcomm. And my dad's voice is on one of the first internet transmissions of voice across the country in the 1970s. It's pretty awesome. I don't know why this is advancing on its own. It's kind of doing what I want, but whatever. So then he met my mom, who's a chemist, at graduate school. And they had me, and the family tree is growing without my touching it. So my first part-time job was grading chemistry exams. I did a multiple choice grading before there was Scantron or anything like that. And those are my 2 brothers. And my brothers and I were all actually participants in the Research Science Institute because one of my brothers was very gifted in mathematics, and we were on some mailing lists back before the internet. It was hard to find out about this stuff. And so we got a mailing about the science program, and my mom said, fill out the application, see how it goes. And it really changed my life in a lot of ways. And in one way was that I met my husband that summer at science camp. So be careful what you advise your students to do. You never know what will happen with that kind of thing. And we have 3 kids in the public schools, and I get to say now that I appreciate all of what you all do for them. And there's more RSI students coming next generation. This is me and my science teacher in middle school. This is Mr. Pope. You can see how I look up to science teachers. Mr. Pope is actually, I am short, but Mr. Pope is really tall. And this is my first science project, which actually was a do-it-yourself, like in the basement kind of project. At the time, radon was like the big health scare, like poisoning, radon. Like there's all this stuff that's scary. Radon was the thing that was kind of in the news at the time, and they were selling these radon test kits for $10. And so I bought a whole bunch of them and sold them to all my friends at school. And I put together a map of our town, showing where the radon was in the town, thereby driving the property values in the town down by percentage for this. I won an award. But this is the kind of teaching I get to do now in science class. So this is me and my son, and I'm teaching about how the kidneys work with the kidneys for kindergartners. And I bet that you guys are at the level where this wouldn't happen, but when you tell kindergartners that what you study is the organ of the body that makes pee, everybody in the room seems to have a question, and their question is, can I go to the bathroom? Just suggested. So that's how I kind of got where I was. I got really interested in science in high school, and then I also wanted a component of my career to involve being people. So although I got a degree in computer science, and I thought I would go into science in a kind of more traditional sense, I ended up going into medicine, and I really enjoyed Okay, so here's the science part of the talk. So I'll first talk about thinking about my favorite topic in both in clinical care and in science. falls in the murky middle of this pyramid of, you know, how complicated versus how logical science can be. So when I was an undergraduate studying computer science, we were looked down upon by the pure mathematicians as being kind of, you know, too applied and too, you know, oh, well, anyone can do that, but if you can just do it all in your head, you're better off. And you know, chemistry was more applied than that, than physiology, and I guess I fall somewhere into the physiology, psychology, biology spectrum of this now. But this is a pyramid that I like to think about because often in medicine we think we're understanding something at a higher level, but what we really need to do is understand all the complexity that lies beneath what we think we understand about something. So a couple books that I've found really helpful that have come out recently in terms of thinking about how we characterize data in science are Daniel Kahneman's book, which is called Thinking Fast and Slow. Kahneman won a Nobel Prize in Economics for ideas about theories of how we come to solve problems. So do we solve a problem kind of by anchoring to our first solution? If I suggest an answer to you, does that change the answer that you give me? If I tell you that something is 99% successful, are you more likely to take me up on the treatment I offer you than if I offer you a treatment that has a 1% chance of failure? And what if I offer you a treatment that has 0.5% chance of failing in one way and a 0.5% chance of failing in another way? Or what if I offer you all 10 ways that it can fail 1 in 1,000 times, right? So, you know, how do I kind of cast my data, which is the same data presented in different ways? How does that affect how people think about things? Jerome Berkman is a physician at one of the Boston teaching hospitals who's written a nice book about how doctors think. And using actually a lot of the concepts that Kahneman and his colleague Tversky kind of put together when they were thinking about how people solve problems and what biases people bring to the problems that they're trying to solve. So when I walk in a room, I may have an immediate judgment that is instinctual and maybe correct. It's fast thinking, and it may be really important to have that kind of fast thinking module to what you do. Because it might be right to an order of magnitude, but then there's a slow thinking process that also has to go on in order to fine-tune the diagnosis, or in order to recognize that your first instinct is wrong. So these are things that kind of come in a bit of our reasoning. So here's the interactive part. What is blood pressure? What does that mean to you, either colloquially or physical way? Some people want to throw out a definition of what blood pressure is. On a vessel, yes. Pressure on space, and probably takes some flow to create some pressure. There's some equation like that I learned from you guys when I was in physics. What else?
2 numbers.
2 numbers.
San Diego, systolic and diastolic.
Systolic and diastolic. Beautiful. So there's 2 numbers. Good. On some continuous range, right? There's some impossibly low number and there's some impossibly high number, but there's some range in between. What else?
Sometimes it's good, sometimes it's bad.
It could be good or bad. So what kind of variable would that be? A binary. That would be, so it could be either good or bad. Let's just forget about the numbers. Just tell me, is it good or is it bad? So I can leave the office and know whether I'm sick or not sick.
Or at risk.
Or at risk or at not at risk. Healthy, not healthy.
It occurs in a closed system.
It occurs in a closed system, right? If we cut a couple big arteries, we won't have blood pressure anymore. Our problem will be solved. No more problems.
You have very low blood pressure.
Somebody once told me that the most stable, you never want to be the most stable patient in the hospital because it's bad.
It's a vital sign.
It's a vital sign. It's part of the kind of 5 vital signs. We've added pain to the vital signs: temperature, blood pressure, pulse, respiratory rate. Okay? Okay? Those are all great definitions. Okay? I'm going to give you. Okay, so here's some ways to characterize blood pressure, just to get started. So this, in the upper left, we have the classic, the 2 numbers, 118/78. That's blood pressure. We have your idea of risk. Is this, or categories? Is it high? Is it very high? Is it kind of high? Is it borderline? Is it low? So we could put it into categories. We could put it into just high, low, high, normal, low. We do a lot of different things with this number. We can see it as something that progresses over age. So blood pressure, the normal blood pressure, if we think of normal as a bell curve normal, changes as we get older. So it's something that happens through time, right? It's also geography, which is kind of interesting. So it's a geospatial phenomenon. Blood pressure in this country is highest in the states that are here in red.
Fried food, anyone?
Okay? Yeah. So what is the food pattern intake in that area of the country in comparison?
I totally know because I'm from there.
Yeah.
Everything is fried. It's barbecued, little fried, eat
Fried
vegetable. It's, yeah.
And
They're
what
white
are we
People don't
seeing in
exercise either as much as they do, I think, in other parts.
higher sodium.
higher sodium intake? Just the normal sodium intake in that part of the country is higher. Okay. What else is different in that area of the country? Climate. Climate's different, yeah. So actually, blood pressure does vary with climate change over the course of the year. Okay, when do you think blood pressure is lower?
Sleeping.
Summer, when we sweat. Yeah. When we're more physically active and when we sweat, our blood pressure is lower. Okay. That red area of the country is called the stroke belt. And it's called that in research circles because there's a lot of interest in trying to figure out ways to prevent, ways to characterize, okay, ways to understand risk. It actually turns out that the fried food and the salt are only part of the equation. Okay, so here's one set of ways to talk about blood pressure, which is really just 2 numbers. Or maybe it's just yes, no. We can keep making this more complicated. The health reporter from the New York Times, Dena Rifkin, just figured out about November. She just figured out something that I was when I read this article. Sometimes you're so into a topic that you don't remember what you didn't know. Okay, and when I read this article, I thought to myself, wow, this is news. Reading blood pressure seems like a simple matter of putting on a cup, but your numbers can change several times a day. Has anyone checked their blood pressure and had it be different? Okay, so this was the front of the New York Times health section was pointing out something that to me was so much part of my daily life that I had to step back for a minute and say, wow, I've gotten too deep into this research. I got to go back and read the newspaper as much as I can, just so I know where things are at. So blood pressure changes from moment to moment, from hour to hour, from day to day, from day to night, from place to place. Very difficult spatial problem if you're thinking about how to think about data. So here's a little figure that kind of tries to show that. So there's beat-to-beat variability. When you take a breath, your blood pressure actually goes down because you're changing the way that your heart can pump blood out of your chest cavity. When you breathe out, it goes up. And sometimes we have patients in intensive care units where we can actually see this on the monitor. So we're monitoring their blood pressure continuously with a catheter in an artery. 24 hours. What time of day do you think people's blood pressure is higher or lower? I hear a lot of it. At the end of work, blood pressure is high. dinner, it's lower. What about when you're fast asleep at night? It's lower, actually. Yeah, and then early morning, right before we wake up, it comes back up. Okay? So there's a diurnal, there's a normal diurnal pattern to blood pressure. Higher during the day, lower overnight, and then back up as we wake up. Day to day, what day of the week is blood pressure highest? Everybody can't believe that. Monday. And then month to month, year to year. So in large population studies, we always have to do something called adjusting. We adjust for seasonal variability because we know that if you're doing blood pressure studies in Boston in summer, blood pressure is lower than in winter, so you kind of have to play in some adjustment to that. And each of those kinds of variability has been linked to different health outcomes. Okay, so individually and separately from is your blood pressure high or low, if you take medicine for blood pressure or not, there's this different component which is, how variable is your blood pressure? Is your blood pressure normal, variable along normal kinds of patterns, or is it variable in a different kind of pattern? So that's pretty interesting. Here's the 7-day week. I put this in because I was going to make you guess which day was higher. So it kind of goes up as the week starts, and then as Friday kind of gets closer to your site, it starts to go down again. Let me ask you one other question with this day-night variability that I mentioned. Do you think of some people who wouldn't have the day-night, where their blood pressure wouldn't be low at night?
Security guards.
Okay, so if you lived in Alaska, like you didn't have day and night. That's true, yeah.
You had insomnia.
If you have insomnia, you have some sleep disturbance. So there's this disease called sleep apnea, where people, so insomnia is also true, but sleep apnea is a disease where people snore very heavily and kind of stop breathing as they're sleeping. Those folks actually have higher blood pressure at night than during the day. Who else?
How about people who are blind?
People who are blind. People who are blind actually, I think, I actually don't know the answer to that. I don't know, I'll find out. Yeah, so you're thinking about light sensitivity.
Yeah,
What?
a diurnal biorhythm and
Because I would
light.
guess, I don't know the answer, but my guess would be that if you're blind, you still have a pretty good diurnal, you can still maintain a pretty good diurnal rhythm of knowing what day and night are. But I don't know the answer.
How about infants that sleep in
Yeah,
every 2 hours?
It's really hard to do 24-hour blood pressure studies in infants. So I don't know the answer to that one either, but I would imagine that they have lower blood pressure when they're sleeping and higher blood pressure when they're awake. It's not in a 24-hour pattern for a while.
What about people who have switched work schedule?
Yeah, so shift workers get really messed up, and usually they don't even dip during the day. If they sleep during the day, they don't dip during the day because the sleep is not as restful. Who else?
College students.
College students get really screwed up with their blood pressure, as do medical residents. So people who go through medical training who sleep with a pager on. Firefighters who are on call don't have their blood pressure go down when they're sleeping because they're tense when they're sleeping. Battered women, in studies of women who don't feel, or anyone who lives in a neighborhood, there's another geographical variation in blood pressures that people who live in unsafe neighborhoods with gun violence, places where they don't feel safe, their blood pressure doesn't go down when they sleep because they're always on alert.
Soldiers.
Soldiers, yes. I work at the VA, so I see a lot of PTSD also. So it keeps going when you come back. Yeah, so it's an epinephrine mediated process. So it's mediated by the whole autonomic system essentially. The autonomic system has to believe that it's the right time, has to get a signal that it's the right time to relax. And if there's no good time to relax, then you don't know. So we've done studies of this, and I'm going to show you some of them. And what we're looking for in a lot of these studies is the message and the noise. Okay. So this is not a day night. I'm going to show you some day night stuff, but this is over the course of a 6-month period. This patient was checking his blood pressure at home 2 or 3 times a day for us, and we were getting those via kind of a Bluetooth-enabled blood pressure cuff. So he would check his blood pressure and it would show up as at first it pinged, which I couldn't take. I had to turn off the ping. It would show up on my computer screen. Wherever he was kind of internet-enabled blood pressure readings. So this is all his blood pressure readings over 6 months. And we called him 4 times to change blood pressure medicine over the course of those 6 months at those red bars. But you can see, I don't know what this guy's blood pressure is. If we think that a blood pressure can be comprised as a top and a bottom number, this man's blood pressure on any given day could be 190, it could be 120. And after you have all this data, you kind of have a sense that it's going down with time. This is the green dots are the systolic number, the orange dots are the diastolic number. That we did something. It's kind of trending down over time. You can put a trend line through it, right? You can have your students graph this data and they can see a pattern. But what is his blood pressure? Isn't that the question? What's his blood pressure? I don't know what his blood pressure is. I'm really not sure. He's got a lot of variability. And variability is what interests me. So this is very interesting to me. So I can characterize that he's got variable blood pressure, and then I can talk about what are the risk factors associated with that. This is the typical pattern for this. So when we measure ambulatory blood pressure in my research studies, we set you up with a blood pressure cuff that you wear for 24 hours. It has a little hip belt. It goes on your arm. It inflates every 20 minutes all day and all night. Most people only do this research study once. Chance. I did it myself before I sent anyone home with the blood pressure cuff. My husband was not happy because it makes a
So it is worse than snoring.
because it's more intermittent. Snoring is usually a rhythm you can kind of get used to with a bed partner. Whenever we ask about snoring in clinical medicine, we always ask the bed partner. We always ask, is there somebody who you share a bed with? Can we talk to them about your snoring? Snoring you can almost get used to because it's usually rhythmic, this kind of thing. It's intermittent. So we do these studies quite a lot. And we actually get good buy-in, especially with people who are engaged in their hypertension care. And this is kind of what we find when we, so each red line in this, again, data visualization, each red line in this is one participant in a research study. And each blue line is a participant in a research study. And what I've put in the 2 bars there are where their blood pressures were when they were in clinic. 120 and 140 are kind of typical treatment goals. So I might have patients that I'm trying to treat to a blood pressure of 140 and others that I'm trying to treat to 120. That's where these guys were in clinic. And then you see this kind of cloud of where they go after they leave me. So my sense of control is kind of challenged by this, right? Because I think I'm any illusions I had about being the doctor and controlling people's blood pressure kind of goes away when I look at blood pressure like this. Because I know they came into my clinic and I had them at 120, they're a blue line. And then where did they go? Oh my God, they went down to 80, is that safe? What did I do to them? And then they come into the clinic at 140 and then they go up to 160 when they leave. Oh my gosh, I totally missed their high blood pressure. So this is kind of humbling data to look at. So I'm going to now kind of turn the tables on the data visualization, and I hope I've given you some sense of space and time and how complicated this number is when you start to think about it. I'm going to talk a little bit about treatment. So here's a couple quotes from the 1930s when blood pressure was treated with things like bleeding and sympathectomy and terrible medicines that cause depression and I like the one, the greatest danger to a man in high blood pressure lies in its discovery. For then some fool is certain to try and reduce it. Sometimes I feel like that fool. Now this is JNC 8, which is the report that comes out from this commission that reviews all of the high blood pressure data in this country. And they recently came out with a report again, kind of confirming that this is our most treatable medical problem in the United States. We have now 20, 30 medicines that we can use to treat hypertension. They come in combination pills, they have relatively few side effects, and it's kind of provably our best intervention to reduce the risks of stroke, kidney disease, and mortality. And, you know, so when we go to clinic to treat hypertension, we feel like we're really doing something important. But it's sometimes a little harder than that. Anybody know who said this? In theory, there is no difference between theory and practice. That's Yogi Berra. That is Yogi Berra. Yogi would have been a good anything, but I think he would have been really good in our hypertension clinic. I've been counseled in the past that actually your most important skill in hypertension clinic when you go to treat people for a disease that they don't feel, for which you're going to try to convince them to take medicine, is a knowledge of the sports page. Because you're going to have to connect in some way with that person to kind of try to bridge the gap between all the stuff you think you know and where you want them to be. So some kind of connection about something is really important to bring to that clinic. So we've done some, so this is a topic actually that I feel very passionately about, which is understanding adherence, which is to say, do people actually take medicine that we think is valuable for them to take? How many prescriptions, what percentage of prescriptions get left at the pharmacy? Never picked up. Doctor calls it in or types it in or whatever. More than 50%, about 55%. 55% of all prescriptions called to CVS, called to pharmacies are never filled. Never filled. Which is kind of there's all kinds of reasons: cost, fear. There's a lot of things that go into that. So we've done some interview studies. Now this data is not graphable; it's only readable. So I'm going to read you the data. It's hard to characterize this data in any other way. So I think the high pressure pills are most important. We tried to get people to say what's important. If I'm in trouble now, it's because of the pressure. I don't want that to cause any more problems for me. One day I had 120, the next day I had 200. Say, whoa, what's going on inside me? I don't want a heart attack. For somebody who's motivated, but variable, like I just showed you before. I prioritize the blood pressure meds because my pressure is naturally high. I maybe miss a day or something, I just forget. Not really forget, I just don't take them. The next day I go back to it, I don't feel nothing. I keep saying, I'm going to take them, I'm going to take them. And then I'm like, so everything that we know about blood pressure, then comes to these kinds of decisions and people's schedules and how they take care of themselves and whether we've communicated well. We did a study where we took data from patients who were skeptical about medicine in general. And here's a couple quotes from this. Adults have agency and can decide for themselves. In other fields, people use consultants all the time whose advice they blatantly ignore when the advice doesn't fit with their worldview. Fine. Okay? That's true. So, this person needs a different set of recommendations from the person who wants to be taking blood pressure pills but is always rushing out and can't take them. That's a different problem. If I see my job as trying to get the patient and me on the same page. If you read the prescription insert, you'd be dead. But they should have said if you had any side effects such as. They acted as if they were being paid to prescribe it. So trust. pharmaceutical companies in business. I hear a lot of that. And in fact, the way that reimbursement is going in the United States, we are paid to fix it. And primary care doctors are judged on whether their patients reach target blood pressures. So if you are the patient who says, look, I have agency, I asked you for your opinion, you're my consultant, I decided not to do it. I'm not going to get my, my extra payment. So they've done studies of this in Britain where this has been the case for a long time. I certainly didn't realize you had gotten extra payment for taking somebody's blood pressure. Good heavens. Say that in one word, I know what it's like to gear your operation toward hitting target. You ignore so many other issues. So, maybe this person has high blood pressure because of some other problem in her life. Maybe she's under terrible stress. Maybe there's something that should be discussed with this person, but the target makes you treat the blood pressure. What's really interesting to me is that when you ask patients, how many pills would you take for longer lifespan? When you ask people this in theoretic, you kind of pose these questions as economic trade-offs almost. 70% of people, healthy people, not people who necessarily have health problems yet. Healthy, I include people who have high blood pressure, right? Because it's an asymptomatic disease. 70% of respondents to this large study said that they wouldn't trade any expected lifetime for the burden of taking extra pills every day, which is a pretty interesting thing to say. If I said, if you took one pill a day for the rest of your life, you would live an extra year. I find it hard to get into the mindset where I wouldn't do that, but that's not what people are telling us. So, we need to understand the world differently if treating high blood pressure is our priority. And in fact, the splashiest blood pressure trial that's come out in the last couple of years was a trial called the SPRINT study. And it was stopped early because of the benefit of the lower blood pressure target in people who enrolled in this trial. Okay? Their mortality rate was about 30% lower over the course of the trial. It sounds like a big number to me. They had to take one more pill in order to get to the lower blood pressure target. So, these are real trade-offs, and people have really different views about the worth of treatment. So we often face these kind of dilemmas in the clinic, especially when we have patients who don't want to do what we're asking them to do, and we find ourselves in opposition with them. And I think particularly an interesting topic to think about in the era of pay for performance. So suppose you have a patient, he's an old professor at a local magic school, but he's unfortunately sustained a curse that's going to kill him in the next year. Okay, so in the last year of life, it's never really clear that treating things like high blood pressure, which are usually long targets, right? We're talking about exposure of blood vessels to pressure over years, many years, not 1 year. Not somebody who's got a curse, okay? And, my choices are to treat him to a lower blood pressure, make him take pills 3 times a day, or twice a day, or just leave it at a higher blood pressure and let him take fewer pills. Outcome's the same, but the reimbursement models that are being pushed forward are saying that I'll get paid more if I make them take more pills. I feel like that pays me to be in opposition to something that would be better for my patient. And we see a lot of people in similar circumstances, although not as magically talented. So I started with data, and I ended with I think both are important, and when I think about what I like about the science that I do, I like the fact that I get to work with numbers, and I like the fact that I get to work with things that are of uncountable value. And I actually find that my challenge in presenting data that is not countable is much greater than presenting the first part of the data that I showed you, which is the countable data. People respond much more naturally to countable data than uncountable data. And I think that's a real interesting thing to bring up with students, is kind of how to read the literature and understand countable and uncountable and bring those together. I've tried to do that a little bit by writing to the popular press about these issues. This is something I wrote for the New York Times a few years ago when I was quite worried about the proliferation of checklists in hospitals and the illusion that checking 10 boxes on a checklist meant that everything was perfect, and started worrying about what was left off of those checklists. So I think it's important to kind of try to translate what we're talking about into students, how to talk about what they've come to understand in scientific terms in lay terms. And as I said about the Dena article earlier, when I read that, I realized I'd gotten a little bit too deep in. When I realized that how could this be used? I know this so clearly, and I had to back up a little bit and realize, you have to kind of reset yourself to a fresh audience every now and then. So I'll end with a quote by Yogi Berra as well. Anyone who understands knows that you can't understand it. He's talking about